I spoke about asthma previously, and in asthma, the hallmark is reversible airway obstruction. But what happens when the airway obstruction is only partially reversible or there's no airway obstruction? Then we sit with a disease called chronic obstructive airways disease. This video is going to talk through what are the important points of chronic obstructive airways disease and what are the pitfalls we should watch out in insurance medicine. To start off with COAD, there are a few terms we do need to know. Firstly, COAD, which is chronic obstructive airways disease, is often referred to as COPD, depending on which part of the world you are in. Americans are very fond of chronic obstructive pulmonary disease, and the rest of the world is COAD, but it means exactly the same thing. But a lot of people here in South Africa will use this interchangeably with many other terms as well. So do doctors. The first one is emphysema. And emphysema just implies chronic damage to the lungs, but it forms part of the COAD spectrum. The other term that they often use is chronic bronchitis. Patients will come to you and say, "Oh, dokter, ek het 'n bos, ek het die bronchitis en is chronic." And you often hear them talk that language, and we call this still COAD. And the last important part where doctors also view this as COAD is when we say somebody has asthma, but with only partial reversibility. We are actually, in fact, talking about COAD and no longer asthma. So COAD encompasses a large spectrum of diseases, and while there might be subtle differences, they all fall under this umbrella of COAD. So what are the causes of COAD? Well, the top 3 causes you need to know is number 1, smoking. Number 2, smoking. Number 3, smoking. And once you've got that, we add all the other causes. There's also occupation. If I worked in mines for many years, the huge amount of dust particles, and this hasn't been closely monitored, I get a disease called silicosis, which falls under this umbrella of COAD, where there is very poor reversibility of bronchoconstriction in my lungs. The other one is air pollution, similar to occupation. If I live in a very smoke-filled environment for years, that air that I breathe in can eventually cause irreversible damage to my lungs. There's also genetics. Some of us are more susceptible than others. Now, genetics in itself won't cause COAD. It has to have another stimulus. This is why we will see some smokers who's been smoking for 2 years who has COAD, and others who've been smoking for 20 years and they brag to you and say, "I don't have any COAD." That may be true, but that's also about the genetic susceptibility. And then we also see those who've had some sort of allergic reaction or allergic sensitivity, whether that was hay fever or asthma, and because of poor compliance or poor treatment modules, they have now had some permanent damage to their lungs, and that is how they ended up with COAD. So what are the signs and symptoms of COAD? Well, they're very similar to someone having an asthma attack. However, this history will tell you that there's no breaks of normalcy between these attacks of feeling short of breath. So classically, somebody will start off with, "Doctor, I notice I'm getting short of breath when I do exercise now," to eventually becoming over months to years a point where they feel short of breath at rest. So how does chronic obstructive airways disease lead to a poor prognosis? Well, we have this anatomy and physiology of the normal alveoli and where gaseous exchange takes place. In chronic obstructive airways disease, we see that these bronchi and the alveolar walls are damaged because of constant exposure to either chemicals or poor compliance when it comes to asthma. And because of this damage, it decreases the lumen. So we're getting less oxygen in. At the same time, we have more mucus production. And this mucus production, because it's very difficult to get rid of it because of convoluted, damaged airways, then becomes, in fact, a house for microbes and germs to multiply. And this combination ensures that gaseous exchange is at the bare minimum and gets worse over time. In an effort to compensate, the alveolar sacs actually become larger and start ballooning. But these ballooning parts of the alveoli are called cysts. And they don't do gaseous exchange very well, but in fact only become a holding area for more mucus and more microbes to become multiple and cause more infection in the lungs. As a result of all this poor gas exchange, the body is now in a chronic state of hypoxia. It's not getting any oxygen. It's tried to expand its lungs. We're seeing hyperinflation. Organs of the abdomen has moved down, and still we're hypoxic. So what's the next thing the body does is increases the heart rate. If we brought more blood to the capillaries, then even that minimal gaseous exchange will be utilized to get oxygen in. But pumping blood so hard for such a long time, over time, also weakens the heart. So not only do we sit with a state where the lungs have a problem now, we also sit with a state where the heart has a problem. And eventually, because of fibrosis in the lungs, we sit with right heart failure as well. Another word for this right heart failure is called cor pulmonale, because what it tries to imply is, as a result of a lung problem, we're sitting with right-sided heart failure. So how do we attack or treat chronic obstructive airways disease? Well, if the diagnosis was correct, the bad news is we can never reverse it. But we can slow down the progression or stop the progression. First thing first, we try to remove the triggers or those things that hasten the progression of COAD. So, without a doubt, if a smoker has COAD, they have to stop smoking. No, we can't reverse the damage done, but we at least can stop the rate at which it's progressing to this end stage. We must also remove any triggers or stimuli. It's often thought that there are dietary influences that make some people's COAD hasten far quicker than others. We also start using inhalers because the part that might still be reversible will be sensitive to these beta agonists that we use as part of the asthma spectrum. We will use this in COAD patients where we feel that we can reverse some of it. We'll also use oral medication. We may include bronchodilators, corticosteroids. The same approach that we have with asthma, we'll have with COAD. One big difference, though, is once we have a chronic state of hypoxia, the only thing that's going to matter is getting more oxygen in. So very often, near end-stage COAD, the person will be prescribed an oxygen tank. And this oxygen therapy is a telltale sign of how severe the COAD is. There's also respiratory rehabilitation. Physiotherapists, occupational therapists will sometimes assist the person, telling them effective ways to have a far meaningful breath so that maximum gaseous exchange can help. It helps a little. But once we've reached end stage, this rehabilitation does not really make a difference. And then there's surgery. Sometimes COAD only affects one part of the lungs or only one lobe of the lung. In those instances, it is actually better to have it surgically removed than have it there and compete with the rest of the normal lung for oxygen, because that makes less oxygen delivery. So you'll find that some people with COAD had a pneumonectomy, which simply implies part of the lung has been removed, lobectomy, which implies a lobe of the lung has been removed, or bullectomy, which implies one of those large cysts, which we call a bullous, has been removed so that the normal lung or the relatively normal lung can have better gaseous exchange. So how do we assess severity of COAD? Very similar to asthma, we look at frequency of symptoms. We usually look at serial symptoms over the last few years, from what started off as perhaps misdiagnosis of asthma or just shortness of breath when I have flu-like illness, which we all have, and no, not all of you listening or watching this video has COAD. But classically, the history starts with I was feeling short of breath just when I was feeling ill, and then it started with exercise and got worse and worse. We also look at the degree of breathlessness. How short of breath are you on walking 20 meters? How short of breath are you on dressing yourself? And the closer to home, or the closer it affects daily activities of living, the more severe your COAD is. We also look at frequent hospitalizations, which indicates how severe your COAD is, and the need for oxygen therapy, whether you've been placed on oxygen therapy as well. When you are hospitalized for COAD, they're not only going to do lung function tests as we see with the spirometer or the peak flow meter, but they're going to do blood gases. They actually take a sample of arterial blood gas, and they look at that to see what's the oxygen concentration in that blood, to tell us whether or not you're getting enough oxygen to supply the important organs. And then, as I stated, they will look at serial spirometry to predict the rate at which your COAD is progressing and whether the current management is making any difference or not. So in insurance medicine, the one big key thing that we look at to tell severity is not just symptoms, but we also look at the spirometry results. Now, I wish to emphasize it's not always possible to get serial spirometry results, but it's far, far better to look at the bigger picture than just one picture. And we assess the severity of COPD or COAD with regards the spirometry results. There's something called the FEV1. How much air you expel in the first second of your exhalation tells me how open those airways are and how well you can breathe. If it's more than 80% of what's expected for someone that's your gender, your ethnicity, and your age and height, then we say that that is mild COAD. Anything less than 80% falls under moderate or severe. In the moderate category, we'll look at why it may be moderate now, and is there a chance that this will become mild with better management. Anything that involves severe, which is less than 50%, we would not consider giving cover in insurance medicine, as that risk is far too high. But moderate would be referred to the medical division of your company to see whether or not there is room for improvement and whether the person can actually have some life risk products. By the way, FEV stands for forced expiratory volume. So as I stated, how much air you're forcing out of your lungs after you've inhaled it. The FEV1, the one indicates how much air I'm expelling after 1 second. Sometimes you may see on a report FEV 25, that means how much air you expel in the first 25% of the exhaled breath. Or FEV 75, how much air you've expelled in the first 75. Those ones are more for the respiratory physician to note subtle differences. We in insurance medicine concentrate on the FEV1. So unlike asthma, COAD often carries a poor prognosis. And it isn't often that we give risk products in insurance medicine for people with COAD. We would consider, as I stated, if there's a presence of mild or moderate COAD with the potential of improving over time, or with the potential of this is not going to get any worse significantly for the next 5 to 10 years. Otherwise, we assess it quite harshly in insurance medicine, and it is based, as I told you, on what are the complications or the outcome of COAD. Well, I hope that this has been of some use to you when you underwrite or assess COAD.